Hello and welcome to this first of a 5 series video where we bring heads of hospital associations from different countries in Asia to share their COVID experience and find ways to work together to battle COVID and its economic implications. Questions to the speaker? Feel free to write in the comments bubble below. For this first video, you will hear from Dr. Kuljit Singh, President of the Association of Private Hospitals, Malaysia.
I represent Malaysia, which is a very small country compared to all of your countries that we have. We only had about 38 million people, so our measures are a little bit different, and we have been pretty successful with what we had. We have been under a movement control order since 18th March, and that has helped us a lot because we do not get our public to move around, and that has brought in the numbers down very much down than what it was going on in the month of March. But our method of testing is basically we identify the cluster in which we feel that's where the spread is going to be, and we go to that cluster and test. We don't do mass testing yet. One of the reasons is because we don't have the facilities, but now my good friend from Korea is able to sell to us, then we may go for mass testing. But right now we are only using the PCR testing, which is based on a lab testing. So we secure and conserve our resources for targeted population, which we feel it could be a potential cluster. The good thing in Malaysia is the entire COVID management is done by the government hospitals. They're doing it very well. And it's all managed by them, it's all paid by the government hospitals. And we in private have not seen any COVID patients that we manage. Everything is done by the government hospital. What private hospitals we do with the government is we support the government hospital. How do we support them is we have got 900 beds ready to take over any of the non-COVID patients from them, so that the government hospitals can concentrate on COVID treatment. We have got 501 dialysis slots that we have made it ready for government to send their dialysis patients to us. And we will charge them only at cost price, not at the price with profit. We have given 70 ventilators to the government, functioning ventilators to the government, because there was a time that it was difficult to get ventilators from the vendors. And nobody wants to sell you ventilators right now because everybody wants the ventilators. And if you get a ventilator from outside, you are not sure whether the ventilator would be of good quality, whether it functions well. We are giving them functioning ventilators. We loaned them 70 ventilators. We prepared our private specialists to go to the government hospitals if they require our help. Respiratory physician, infectious disease specialists, anesthetists, we are all on standby to help the government if they need our help. We are willing to take over the non-COVID patients if they need. But it's good news that so far they don't need our help. They've been doing fantastic. We are ready to help them, but everything's actually going quite well. Now, what we did was we did a lot of public-private partnership meetings. So this was a good, in a way, it's a fortunate thing for us that this COVID has allowed us to do private-public partnership in a very seamless manner. So we are discussing, we are in groups together, we are in WhatsApp groups, we do webinars together with the government, constant teaching from the government, so it has been very good. Now what the private hospitals did is one thing which we don't realize, if we get a patient transferred from the government to private hospital, there was an issue with the indemnity cover. Because some indemnity will say if you transfer a patient from the government hospital, the government has to indemnify. But we have managed to get all our indemnity companies in writing that they will cover the government or private hospitals if they take over any public patient. There's a difference between a transfer patient and there's a difference between a referred patient. Referred patient should not be a problem because then your indemnity will cover. But when you get a patient transferred, there is an issue with some of the indemnity companies, but today we've got letters from them, so that's not a problem. We do testing. The testing that is done in the government hospitals are basically for PUIs. Those are patients under investigation, they are high suspects, but the private hospitals are doing the other testing which are not PUIs. If a member of the public feels that he wants to get tested, they can come to the private hospitals, they could drive in, they don't have to come out from the car, we do the testing in the car and give them the results in 24 hours at a very nominal price. So since the city is under movement control order, we get the appointments done through application on our telephone, and they can come to any of the private hospitals, drive through and get the testing done. And that has been working very well. We are ready in private hospitals. If the cases become really bad, we are willing to even take over the COVID patients. But for the timing, because we want to contain the disease in specific areas, we left it for the government to do it. All elective patients, we stopped all elective surgeries, both in public and private. But in the last 1 week, the private is slowly opening up to do elective patients because some conditions you cannot keep patients waiting. It's already 6 weeks, and that conditions which are elective may become emergencies. And that's not good. We do not want that to happen. But every elective patient, every admission in a private hospital, we do COVID tests. And we separate them into a ward, which we will classify them as a PUI ward. Until the COVID test is not ready, they are kept in a separate ward. And once the test comes back as negative, then they are sent to the normal ward. And nurses, doctors in this ward, when they're waiting for the COVID test, they have to wear PPEs. Once you go to the normal ward and they are COVID negative, they don't need to have PPEs. So we are doing that. We have already started. Patients are beginning to come back. It's also an economic issue. Most private hospitals cannot survive too long with their cash flow if we keep locking patients out. And patients would want to come, and we have to start somewhere. And the government has been pretty supportive on this. We are looking at teleconsults. There's a lot of restriction in teleconsults. Our laws don't allow teleconsults that easily. We can have some communication, but the government is sometimes worried about who the doctor is and whether the patient is getting the right information. So we have minimal teleconsult, but prescription online and things like that is not allowed because you have to examine patients, you have to see patients for patient safety. Those issues are still not done. What our main issues is PPEs. We don't get enough PPEs, especially the N95 mask. We tried ordering from China and sometimes we don't get them. So we have those issues. We do have enough, but we know in a couple of weeks, if we don't get PPEs, masks, we might run short of PPEs. So we are working very hard. We are working together with the government so that we can share some of the resources that comes into the country. But if Korea can start making PPEs and N95, probably I'll fly myself to Korea and collect it from my good friend. So we are hoping that that is our worry. PPEs is our worry right now. And we are looking at the Korean rapid test. We have the antigen test that was introduced in Malaysia. They did test, they found the specificity and the sensitivity was very good. Rapid antigen test that the government has looked, and the government of Malaysia has bought 200,000 kits from Korea, and which they're going to start very soon. Now, our next step is looking at the antibody rapid test, if there is one, and we would want to buy that. And once we get the rapid test, then we are going to go and do mass screening. So this is basically how we have worked it out in Malaysia, our partnership with the government. As I said, it cannot be compared to some of your countries because my country is very small population. You can travel anywhere quite quickly, and we managed to control because of that reason. And we only anticipate the MCO may get extended because we are doing well. Doing well doesn't mean that everything is good. The moment you let go your control, the numbers may go up again. So that is one thing that we might control because Ramadan is starting day after tomorrow. There's the Muslim fasting, and that's where sometimes the spread might increase. So that's in brief.
Gyani.
Dr. Gyani, yes.
Yeah. So, Dr. Kuljit, the last week we did random sampling testing in those areas which were considered as a red zone. And what we found a new trend now, 70% of the people who came positive were actually completely asymptomatic. There were no symptoms. And hardly 23% cases were symptomatic who came positive. So is the trend also being seen in Malaysia or maybe even in South Korea?
Yeah, it is true because 30% of the patients would be asymptomatic. They will have COVID positive. But when we find a COVID positive, we quarantine them for 14 days. And in Malaysia, we're quite lucky. We have taken some good 4-star, 5-star hotels and put them into that place. If they have no symptoms, of course, if they have symptoms, then they have to go to the hospital.
Yeah.
So this is a dangerous trend, which we have to face in time to come till we completely eradicate.
We are hoping that we get a vaccine soon and testing, antibody testing. Then we know who is positive, who is negative, who has got antibodies, then vaccinate the correct group of patients. But the problem is what we read, there are 30 over variants of coronavirus genes. That's what I read somewhere. That's going to be challenging, but I'm not sure whether Korea is looking at a vaccine or not. I think it's very tough.
Dr. Wang Jun Lee, is Korea looking for a vaccine? Are you in the...
Yeah, we are trying to develop a new source of the vaccine, and also we organized a very special committee to support this vaccine development, not only with the pharmaceutical companies, but also with the research institutes. But in my private opinion, the vaccine development is very hard course compared to the previous experience in MERS virus or even in SARS virus, because the influenza virus is rather easier to the coronavirus. So we are trying hardly, but the vaccine development would be a little bit tough. And as for the percentage of the patients, the symptomatic stages, so the whole statistics is very similar to China or the other countries. So 80% would be the mild status of the patients, and half of them, that means that up to 40% would be asymptomatic or very, very, very mild symptom. Even the patients cannot feel he got such like a flu symptom. So that would be very subjective symptoms. So that is the reason why this coronavirus would be so easily spread. But we also found that according to the severity of symptoms, the infectivity would be related to symptoms. Anyway, so symptoms is severe. Anyway, the infectivity could be increased. But even the symptom is not so distinctive, but the infectivity could be sustained. Can you understand? So the correlation is only the symptom increase, the infectivity is increased. But even there is no symptom, but the infectivity is not decreased. Ironically, so there is very curious problem for the transmission infectivity of this novel coronavirus.